Good afternoon, everyone, and welcome to the first of this academic year's Bradford Hill Seminar. For those of you who might be new to Cambridge, this is the joint seminar series of the three departments that are involved in the Population Health Sciences Partnership, so the MRC Biostatistics Unit, the MRC Epidemiology Unit, and the Department of Public Health and Primary Care. We're very pleased to welcome Professor Jaki for this first talk. Just a couple of housekeeping notes. The presentation is being recorded, just to make sure that you're aware, everyone online. And if there are any questions, either raise your hand if you're online or in the audience, and we'll call on you to ask your question. There'll be one more Bradford Hill seminar this term in 2 weeks' time, where we'll have, I think, an interesting talk on qualitative experience of patients suffering from long COVID. So I'll now hand over to Hyan, who's chairing today's session.
Hi everyone, it is my great pleasure to introduce you to Professor Thomas Jaki, who is a professor of statistics in both the University of Cambridge and the University of Regensburg. While I have a lot to say about this man, I promise that I'll keep it very, very succinct. So I have known Professor Thomas Jaki since 2015, although I have read many of his papers before that, and he's an excellent supervisor, mentor, and a collaborator. His expertise and the research is mainly focused on developing innovative statistical methods for clinical studies. And let's welcome Thomas to share his experience in designing trials during a pandemic. The floor is yours, Jack.
Thank you. Thank you for the kind introduction and the invitation. As the title says, I'm going to reflect a little bit on some experiences in trials during a pandemic. But before I go into this, I thought it's probably useful to just start off by thinking about what do we do if there isn't a pandemic? So what do we think about in a clinical trial in the first place? So let's look at a very simple example. A horrible disease, sudden onset arithmophobia, is a disease that's affecting students that prepare for math examinations. And typically, a student just wakes up one day and just can't do any simple math anymore. The course of the disease can be a few hours, can be a few days. But the problem is, so far, there is no known cure to it. Professor James Moriarty, however, says he has developed a 2-hour hypnosis therapy that will help sufferers from SOA. And he claims even that 3/4 of sufferers are going to be cured from the disease after undergoing the therapy, his therapy. And now the obvious question to you, if you're suffering from this debilitating disease, is, well, would you undergo Professor Moriarty's therapy to treat this disease? And I'm going to hold it by Sherlock Holmes, who responded to the question by Watson, what's the meaning of all this, Mr. Holmes? Well, I don't know. I don't have any data. I cannot tell. And so the first thing we're going to want to do is make sure that we're going to collect some data to make an informed decision about whether or not this treatment truly is helpful for sufferers from this disease. Now, Ronald Fisher, famously about 100 years ago now, said that talking to a statistician after you've done your experience, after the experiment, after you've collected your data, is just asking him to do a post-mortem examination. He can only tell you what the experiment died of. So what does this mean? It means we're going to have to think very carefully about how we're going to collect our information, our data, and how we're going to make our decision at the end. And this is where clinical trials come in. So what do we worry about in practice? Well, we want to collect some evidence and we want to judge whether or not the level of evidence that's provided to us reaches a certain bar, crosses a certain bar, and if the evidence is strong enough, then we're going to be happy with that treatment going forward. If the evidence isn't strong enough, then we say, no, sorry, doesn't look like that treatment is going to be helpful. Now that's a rather simple thing to think about, but what do we worry about? Well, obviously with any decision, we're going to worry about getting things wrong. So what kind of things could we worry about? Well, two different types of errors are of interest in particular. We can either say, yes, the treatment is better, it crosses our bar, when in reality, it's not. So we take the action, we say, this treatment is better, when actually we shouldn't have. And that's what we call a type 1 error. And what we want to do is we want to collect our data, we want to investigate, make our conclusions in such a way that this error is as small as possible. And in practice, for our clinical trials, what that does is specifying this type 1 error specifies how high, how difficult it is to cross this bar. If we allow for a lot of type 1 error, we set the bar very low. If we allow very small type 1 error, we're going to set the bar very high. Now at that stage, obviously, I think the logical answer, just thinking about this type 1 error question is, well, obviously, I don't want a high type 1 error, so I'm going to set my bar very high. But then I'm going to be risking having my second type of error, my type 2 error, that my conclusion is, no, the treatment isn't any better, isn't doing anything useful, when in reality it does. And that's what we call type 2 error. So we don't do anything when an action should have been taken. And that error we can use to specify how much information we require before we're going to make our decision. Is it going to be collecting data on 5 patients? Do we need 1,000? Do we need 10,000? That's what we specify, what we can control through thinking about this type 2 error. So those are the first two things that will play an important role when we think about a clinical study within a pandemic or without a pandemic. The second is thinking about what should we base our decision on. We're going to need something that's meaningful for our context. It could be something that's meaningful to the patients, to the decision makers in our case. So in the context of SOA, maybe it is the number of SOA attacks a patient has over the course of a year. That could be a meaningful outcome. It should be something that is easily and reliably measurable. And again, maybe the number of attacks is relatively straightforward to measure. And it should be something where it's quite easy that any change in that metric can be attributed to the intervention, to the treatment that we are going to investigate. So we want to minimize ambiguity in our decision making. And in a clinical trial, we simplify our lives quite a bit because we tend to use a single metric, which we call a primary endpoint, and base our decision about whether or not treatment, not only but chiefly, on whether or not the evidence surrounding this primary endpoint is strong enough for us to conclude that the treatment is better than whatever the alternative is or not. So this is my sort of 7-minute overview of what clinical trials think about in a nutshell. outside the pandemic as well as inside the pandemic. But hopefully what you've already got a bit of a feeling for is that it involves quite a few quite complicated questions. So what is meaningful? What do I need to measure? What's the most important measure? Because we want to reduce it down ideally to just a single one of them that we should be using. It means that in practice, when you start thinking about a clinical study, we are going to be thinking about how much observation, how we're going to make the decisions, and so on. We're going to not think about this for maybe a few minutes or a few hours. We're going to think about that for a few weeks, months even, before we even get to the point that we can even start thinking about collecting data. And here is where my first challenge comes in when I'm thinking about a trial during a pandemic. So this graph here shows the number of cases of Ebola during the 2015 Ebola outbreak. On the x-axis, you see time. On the y-axis, you see the number of reported cases. You can see two different blue shades of lines, basically two different mechanisms of counting how many Ebola cases there were. So you can see somewhere around November, there's the peak in the number of cases, and then things fortunately started to ebb down. Now, what you also see indicated on this graph with the lines is when different clinical trials have started during that pandemic. So just about at the peak time, convalescent blood trial has started, trying to transfuse blood from recovered patients to current patients and hope that that does any good. Other trials afterwards started much, much later in the process. And as you can see, or what I would argue is, looking at that picture, pretty much they've missed the boat, right? In this instance, fortunately for patients, unfortunately for learning about treatment options, all the trials started way too late. None of these trials really had any reasonable chance of answering any meaningful questions, because by the time they were up and running and collecting data, there was no data anymore to be collected. So you could argue that a lot of these trials were done completely unnecessarily because they didn't do what they were intended to do, make a statement, make a decision about whether or not the treatments are useful. So, first lesson for a trial during a pandemic, we want these trials to start as quickly as possible because, first of all, we want to collect information that allows us to make a decision about the treatments in order to help the patients. But also, if we find a treatment that actually does something useful, it will also change the course of the pandemic, right? Because if all of a sudden I can reduce infectiousness of patients through a treatment, I'm not going to see the same kinds of peaks that if I don't have a treatment available. So being fast in a trial in a pandemic is going to be extremely important. Easily said, difficult to do, right? Because in the context of COVID, for example, there were lots and lots of uncertainties. I mean, we didn't even know the disease. We didn't know what was meaningful. We didn't know what the disease was going to look like. How would we be able to decide what a meaningful endpoint is going to be for patients if we don't even know what the disease does? We're going to also need treatments that we can study, right? There's a new disease. We know nothing about it. Why on earth would I expect a particular treatment to provide any benefit? So where am I going to get the evidence base that says, yes, this is something that has potential, I really want to look at it? So all these things obviously are going to be working against being fast. At the same time, you also have the frontline workers that are going to be under immense pressure, right? They're treating patients. They don't want to fill out a 400-page document for every single patient because you're interested in many, many different variables to understand the disease better. You want to be lean in terms of the information that you require the frontline patients, workers to collect for you. So with that in mind, the first trial that I got involved with was the Lotus trial, which started on the 18th of January of 2020. And for those of you who still remember the beginnings of the COVID pandemic, you'll probably recognize or remember that the first confirmed case of COVID appeared on the 31st of December 2019. So about 19 days after the first confirmed case, the trial started. Now, clearly, I've just said this is not an easy thing to do a clinical trial, so we had to sort of give on some of the things that we would have liked to have done differently. So first of all, we needed a treatment for a disease that we didn't know a whole lot about. And so the only option of a treatment to study was a treatment that was already in existence. So lopinavir-ritonavir is a treatment for HIV. And the only evidence base that was available at this point was in vitro studies. Lab studies that showed, yes, in the Petri dish, this treatment does something against the virus. That was the only evidence base we had, but we thought it was more important to have some signal of something that has potential, and then hopefully get to a place where we can answer whether this treatment does something for COVID as well, and wait and build up that evidence base even further. With respect to the endpoint, what we base our decision on, we've used the rate of clinical improvement on this 7-point scale as our outcome initially. Where did that come from? Again, we didn't know what the right thing to do was for COVID because, well, nobody knew about COVID at that point. But we knew about other diseases, influenza, for example. And so this endpoint is something, or a variant of that, that is regularly used in an influenza trial and was therefore thought to be still meaningful. What probably was the strangest thing that I've ever done was that actually when this trial started, it started without a formal design, meaning we didn't plan how many patients we would need. We didn't have a decision rule that told us, yes, we've got a treatment that does something useful, or we don't have a treatment that was something useful. Again, because we didn't have the time to think about these things carefully, but we thought it was more important to collect data in a structured manner, and then in the time while the data is collected, feed in these extra missing pieces. So what happened was then, once time went on, within the next 2 weeks or so, there was a refinement of the primary endpoints, so rather than the rate based on this 7-point scale, was changed to a time to clinical improvement in the patients. So patients had to move up at least one category in this endpoint in order to be classed as having improved. And we did a formal sample size calculation. Now, as it turned out, the trial was started in Wuhan. By the time we were getting close to enough patients, there weren't any cases anymore, fortunately, in the Wuhan region. So the trial never actually got to the place of answering the questions it set out to be. Because, again, even though we started so quickly, the pandemic, at least regionally, ebbed down much more quickly than anticipated. But it meant that we had a bit of time when it became apparent that, unfortunately, this wasn't the end of COVID. COVID is going to be a bigger problem, much bigger than just within Wuhan. We had time to think about, so what do we actually want from a good clinical trial during a pandemic? So this is my personal list of the perfect trial during a pandemic. I'm sure everybody in here can add things and possibly disagree on some of the points that I'm going to show, but this is what I thought was very important. So it needs to use a meaningful endpoint. Okay, that's not different as for any other clinical trial. But ideally, it's also an efficient endpoint. In other words, ideally, I need to recruit relatively few patients in order to make my decision. It should have the ability to weed out treatments that aren't helpful very quickly, because the evidence base for these treatments is going to be very weak. It's going to be petri dish. Petri dish is not the same as what the treatment does in a person. And therefore, chances are we're going to look at treatment options that aren't particularly good, and we want to get rid of them as quickly as possible so that we can study the things that have more potential. Based on the same argument, it should be able to cope with multiple treatments, again, because effectively any antiviral at this point could have had the potential of being helpful in COVID as well. And ideally, you minimize the burden on the frontline staff in terms of data collection, in terms of decision making, and obviously the list can go on and on and on. But probably the most important thing is whatever you're planning in a vacuum, you're planning with very, very little understanding about the disease, about the cause of the disease, and so on and so forth. So you need to be prepared to change your plans. You need to be able to be adaptive in your trial design. So based on this list, and obviously there were other people involved, lots of other people involved in that decision, we started setting up what became the recovery trial, which is a multi-arm platform trial. Now, the endpoint that was used in the study, or is used in the study, is mortality at 28 days. And rather than collecting lots and lots of information, it uses routinely collected data. It uses electronic health records data wherever possible to minimize the burden on the frontline staff. So this is what recovery looked like during the first couple of months of the pandemic. So the trial started on the 19th of March, comparing 4 different treatment options to standard of care. Now, if you can read that handwriting, you will find lopinavir, ritonavir still in that mix, because unfortunately we couldn't make a definitive decision in the Lotus trial about it, but also other treatments such as dexamethasone and hydroxychloroquine as treatment options. Again, because we wanted to be fast, we wanted to start collecting information as soon as possible. This also meant that only about a month after the trial started, we've already added an additional treatment to the mix, because we had additional evidence that this is a treatment that might be useful in patients. So tocilizumab was added to the trial. Another month later, convalescent plasma was added to the study. Wasn't available at the beginning because there weren't enough patients that had recovered from the disease, so you didn't have enough plasma available to use. So had to be delayed, and rather than delaying everything for 2 months, we felt it was important to collect information on the things we could collect information on as quickly as possible. A couple of days later, first decision, hydroxychloroquine doesn't do anything useful in that disease. A couple of days later, first success was identified, and so on and so forth. Now, the trial is still running, it's still investigating treatments, but generally speaking, I think it's been a great story. So within the first 3 months, 11,500 patients had been recruited to the study. Just under 180 different centers recruited patients. Patients included in the trial were between 0 years old, and I think the oldest to date was 102 in the study. And it took 9 days to recruit the first patient once we had collected we've had the okay on the funding for the study, which is great. But obviously, you can always do better, right? There are obviously things that you might question. So we had included treatments in the study, and we still are including treatments into the study. But is it clear how, when, and what to include in the study? So, for example, convalescent plasma was added to the study in a factorial manner, so that patients would receive one of the 4 initial treatments, and then also were randomized to receive either convalescent plasma or not. So they would end up with 2 treatments, making it much more difficult to disentangle which one of the treatments actually gave any effect, if any. So that's not clear, still not clear to me whether that was the right choice, for example. The trial didn't have a formal stopping rule for about the first year that it ran. Basically, the question of, do we have enough evidence about the treatment, was passed on to the data monitoring committee, which, by the way, did an absolute fabulous job at it. But I wouldn't want to be in their shoes and make that decision without any guidance from the investigators. But probably from my point of view, the biggest challenge was because mortality was used as the endpoint, the trial required huge sample sizes to answer any of the questions. So about 6,000 patients in total per question were necessary in order to get a definitive conclusion. And so we started to think about a bit more what primary endpoints we could consider. This was more sort of as an academic exercise because the trial was running, but we were interested to see whether alternative options should have been considered and could have been considered, and in fact were considered in other trials. Now, about 5 years ago, Whitehead and Horby made the statement that if you're faced with an unknown disease, it's almost certain that having recovered from that disease versus not recovered is almost always a meaningful endpoint to the patients. And I would hope everybody in here agrees. But effectively, in the context of COVID, that means mortality, yes or no, just like we've had in the recovery study. There were these ordinal scales that we started off with from the Lotus trial. So this is pretty much the same kind of scale that we've seen before, except there's one extra category that's been included here following a recommendation from the WHO. So we could use one of those, or we could use some biomarkers, something to do with oxygen saturation, for example. I'm going to sort of ignore the biomarkers for the moment on the basis of it might be very useful tools to identify treatments that are potentially useful, but probably are pretty meaningless to the patients. So what I'm going to think about next is, okay, we got the mortality, the recovered, no recover, not recovered as an option. And we got some form of categorization of different states of the disease that might be interested in, that we might be interested in. How could we analyze, how could we investigate, make decisions on the basis of these ordinal scales? So I could just do a proportional odds model, which obviously it's called a proportional odds model because there's a proportional odds assumption in the background, which may or may not be appropriate. There's a bit of a risk that we're going to say, oh, I'm going to look at my odds ratios at day 7 or day 14. What if that's the wrong timing for that assessment? And probably my biggest challenge with such an endpoint is, how on earth do you interpret what you find there? I mean, even statisticians struggle with interpreting results of a proportional odds model. How is the general public going to ever understand what you've gotten out of this. So definitely a problem. I could take a time to approach. So time to recovery, time to improvement. Obviously has a little bit of an issue as well, because effectively my 8 different categories, I just dichotomize into recovered, not recovered. But at the same time, I'm going to account for the time course. So I lose some by discarding some of the categories or collapsing categories, but I might gain something by thinking about the time course as part of it. That, from an adaptive designs perspective, has the advantage that if I have a time to endpoint, it's quite natural to use incomplete information, time to event analyses, which is great if you do interim analyses where you don't have information on all the patients or complete information on all your patients. So that's useful. How you deal with death in that case, also not quite clear, because obviously dying early is arguably worse than being discharged very early, right? So you can't just say somebody that dies gets a time of 1, dies on day 1 gets a time of 1, and somebody that gets discharged on day 1 also gets a time of 1. So there's a bit of an issue there. So if I'm thinking about time frame of a month, maybe I set death to be 31 days, 60 days to deal with that, but that's also not ideal, I guess. I could just sum up things, right? I could just take the scores, look at the scores on given days and take a sum of them, or a mean or whatever floats my boat, how I want to summarize them. Again, quite difficult to interpret and has a bit of an issue if the observation period is very long, then you're going to lose any granularity on effects, because eventually everybody is going to end up either discharged or dead in this case. And so the longer you wait, the less difference you see between treatments. Okay, so in order to understand what the implication of these different ways to analyze these ordinal outcomes was, we did a small simulation study. So this is 100 different random trajectories, pretend patients if you want. Time since randomization is on the x-axis, and the outcome, my 7 categories, on the y-axis. Note I didn't have the 8th one on because death is a rather difficult outcome in this case to work with. So you can see the different trajectories, some going up towards bad states, most of them in this case go to sort of positive discharged states. The solid lines correspond to sort of your average across your different groups. So red corresponding to the control group, to the placebo group, blue corresponding to the active group. And so in this setup, you can see there is a positive effect of the treatment that's sort of consistent throughout. And that's my baseline scenario that I'm going to look at. In addition, in my comparison, sorry, it turned out a bit smaller than I wanted it to be. I've got a couple of other scenarios to look at. So the first one referenced, that's the one that you've just seen on the slide. The one underneath is a lag treatment effect. So for the first week, there's no difference between the treatments. And then they're going to separate out in the same way as in the reference. The third row is anybody who's going to recover is going to recover faster than in my reference setting. Fourth row corresponds to the same overall pattern, but generally more patients die. And the final row corresponds to there's no difference other than mortality. So if you survive, your trajectory on both treatment arms is going to be exactly the same. It's only the proportion of patients that die that's different between the two groups. The columns correspond to my different analyses methods. So the first block corresponds to my proportional odds model. The second block is just the mean score over time, over the 28 days. Then there are 3 different versions of time to a 2-point improvement. So if you started at a category 3, you would have to reach category 1 before you've improved. If you started in category 6, you would have to reach category 4 before you'd improve. Time to recovery meaning you're discharged from hospital. So no matter where you started, you needed to reach, I think it was category 2 or better. And time to death, well, pretty obvious what that is, just your survival time. And as a comparison, my mortality endpoint recovered, yes or no, at 28 days. So what's the big picture? Well, as expected, if you use something like mortality for the same number of patients, the power, unfortunately, is going to be relatively low. So even though this is probably the most relevant endpoint that we have, it means we require more patients to get the same certainty, to get the same power for our study. The only exception to that is the case where there's only an effect in the mortality and everything else is the same. Not too surprising, I would hope. The other observation is actually whether you use a proportional odds model or use a mean score or you use a time to something, actually the power turns out to be pretty much similar no matter what you use. Now, obviously, there are some small differences and some differences that are expected. So, for example, if I use a proportional odds model that looks at day 1 and my treatment effect only starts after 7 days, I have no chance of finding anything because I've just looked way too early. Not a big surprise, I guess. But other than that, for the most part, the values, the power values, yes, they are different ever so slightly between the different analyses methods, but overall, they're very, very comparable. Which for me means, because it's much easier to interpret something like time to recovery than a proportional odds model, it's much easier for me to do an analysis early with incomplete data with a time to. I would prefer the time to event versions of the outcomes over a mean score or proportional odds model.
Precisely.
Okay, so that leads me to another aspect. I mean, with the recovery trial, from a trial perspective, we got lucky, right? Because we could recruit lots and lots of patients. Reality is, hopefully, that for most outbreaks, eventually the outbreak will wane. What do we do if we started our study, but before we got to the point of making a decision, there aren't any cases anymore? Well, in the context of COVID, at the moment, there are 2,200 trials in COVID running worldwide, about 100 of them in the UK. Clearly, if we just make decisions on relatively small numbers, there's a high risk of incomplete, of underpowered study, a large risk that we're going to make decisions about treatments, possibly discarding treatments as not useful without having sufficient information about them to make an informed decision. So Dean and colleagues have proposed, actually, before the COVID pandemic already, a collaborative approach to working in a pandemic setting. Basically, the idea is that when you do a trial in a pandemic, you have a core protocol, and that core protocol is essentially the same whether you're doing a study in Argentina or in Switzerland or in Japan. It's the same core protocol. And that's important because it means that things are comparable, or as comparable as they will be, even if the data come from different sources. Then they suggest that if it turns out that you can't recruit any more patients under current outbreak, you look at your data, use an alpha spending approach, which is a way of making decisions when you look at your data at one point and might decide to either continue recruiting more patients or conclude either because things are looking great or things are looking terrible. If your conclusion is, I cannot yet make a decision, you're going to keep the details of the data, your results, under wraps until there's another outbreak that's comparable. Think about the Ebola setting, right? I mean, I've used the 2015 Ebola outbreak. How many small or large outbreaks of Ebola have we had since? More than one, certainly. So the idea is you would keep that information under wraps. You would restart the study once there's a new outcome, a new outbreak, and then combine the data, restart your protocol until you have sufficient information to make a conclusion about the treatment that you're investigating. Obviously, it isn't exactly without any problems, because obviously the populations need to be the same, the disease needs to be the same. The treatment still might need to be promising, right? If your outbreak happens now and the next one is 20 years down the line, probably you have a better understanding of treatment options by then, and the original treatment might no longer be the most useful one. But at least for relatively regularly occurring outbreaks, this is definitely something that you could consider. I think you had a question?
Yes, I had a question. When you say this, if no definitive result is is shown, what do we mean by no definitive result?
So basically, the way that these alpha spending approaches work is you set different levels of bars depending on how much information you have. And so if you cross the bar with limited information, that's great, that's definitive information. But if you don't quite reach that bar, you continue on until you have more information, look at a slightly lower bar, because now you have more information to work with, and look at your data again.
All right.
So how do you spend alpha? How do you set that up?
That's a good question. I think I can't remember whether there's a specific proposal in the paper, but what we had discussed as part of this was definitely be conservative. So set the bar for small sample sizes very high. So OBrien and Fleming type stopping boundaries, if that's something that you're familiar with. Okay, question started just before I'm getting to my conclusions. I mean, the first thing to say is obviously a well-conducted trial is still a gold standard within for evidence gathering, whether you're in a pandemic or outside, and that shouldn't change. But because of the uncertainty in an outbreak setting, in a pandemic setting, I think it is crucial that your trials have the ability to be adapted to what you've learned since you started the study. Hopefully, I've convinced you that even though mortality is a useful endpoint, a meaningful endpoint, but because of the large sample sizes required, might not be the ideal choice in many settings. In that case, time to improvement, time to recovery type endpoints provide an alternative with good power that require less time, less patience to make decisions. And finally, whenever you embark in a clinical trial, collaboration is crucial, and even more so if you do that within the pandemic setting. Thank you.
Questions from
Thank you for the talk. You mentioned at the beginning that you were involved in the Lotus trial and the recovery trial.
Yeah.
They shared one of the treatments, right?
Yes.
So you know something about one of the treatments. Can you use the information between trials? Is this something that you can do?
Yeah, so there are plenty of ways that you could think about using other sources of information to influence your decisions. So Bayesian framework in general, obviously, is quite natural. In the trial setting, this is not very common. The argument being that, coming mostly from regulators, that the data need to speak for themselves, and they need to speak for the population that you're studying. And so the argument for the Lotus trial and the recovery trial is effectively that, well, it's a very different region. It was different phases of the pandemic as well. Very, very, very early in the pandemic versus sort of the international expansion of the outbreak, which meant that in this case, they probably, I don't know for sure, but they probably wouldn't have been happy with using that information. I mean, in reality, in this instance, with so much information from recovery in comparison to Lotus, I mean, we had about 200 observations, I think, in the Lotus trial, if I recall correctly, versus by the time we made a decision about lopinavir, we had 6,000 patients. It wouldn't have made much difference in this case. But conceptually, of course, yes, you could use that information.
One question.
I have a lot of questions, as you can imagine. I'll strip it down to one point about adaptive design. I get it, it's great, but in practice, it does take an awful lot of resources when you're introducing a new drug in your adaptive thing. And of course, you might be finding that you stop very, very early in your adaptive trial because of a safety event, an adverse reaction. Sure. So you've spent a lot of resources starting on an arm, but then you abandon not because of efficacy, but because of a safety issue. So,
fair point. What I would say is, what's the alternative? The alternative would be, I'll take this arm, set up a new trial, which would take longer, would cost even more, and I'll need an extra control group, making the problem even worse. So I would argue that actually you're more efficient still, even though it's not the setting that you want to be in.
But what if it slows down the rest of the trial?
Absolutely. Very good question. That was one of the reasons, for example, why convalescent plasma wasn't added as an extra treatment, but was added in a factorial manner, because it meant the number of patients overall didn't change. For other studies that have used a multi-arm setup, we limit how many treatments we allow in the study because of exactly that reason. There's nothing worse than having 4 treatments that you don't have an answer on, if you could have at least answered one of them.
I saw, do you still have a question?
Yes. So with the kind of long-term trials of COVID that have multiple treatments in, would vaccination status confound your endpoints at all? And how do you deal with that?
I'm not sure whether confounding is the right sort of term to think about, but it definitely changes the composition of your population that you're studying, right? Because the patients that end up in hospital have different characteristics. They tend to get older, and so on, have more comorbidities, and that's definitely something that you would want to account for. So in the recovery trial, effectively, the way that we've dealt with that is by using sensitivity analyses with vaccination, without vaccinations, all sorts of different things. But definitely an area where probably one can do much better.
I had a very similar question about the fact that severity appeared to change with each new variant.
Yeah.
So were you having to account for the fact that?
So the severity itself is less of a problem because you're comparing contemporarily.
Yeah.
So even if it changes the same for the control group as your active group. So that issue is less of is less problematic, I think. But yeah, there are definitely lots of factors that need to be accounted for. And if anybody's looking for future methods research, there's plenty in there where I think you can do much better.
Alison said there's one question.
We've got one question online from Svetlana. Svetlana, are you able to unmute to say your question?
Yes.
Yes, thank you very much. I was wondering, how do you interpret the time to improvement or time to recovery for patients who died or patients who deteriorated? So they basically went the other direction, the kind of the direction that's the unfortunate direction.
Yeah.
So would they both have a value of 0?
Yeah, so patients that died were set the largest time that we looked at. So in the not in recovery, but in the ACT trial in the US, for example, they've used the time to recovery endpoint and looked at a time frame of 28 days.
Mm-hmm.
And so if you died, you were censored at 29 days. So you had the worst outcome possible.
Okay.
Amongst the people that you have information from. Obviously makes a difference whether you set it at 29 or 40 days, for example, but in their investigations, at least, that didn't seem to make too much of a difference.
I see, thank you.
Any more questions? Offline or online? Can I ask a question?
Sure.
Yeah, I'm still thinking about the during the pandemic when the variants would happen, and in that case, how would you adapt the trial? Would you open new subgroups to account for the evaluation of the treatment in reacting to the new variant? Or
So I don't think you could sort of recruit subgroups for practical reasons, because by the time you know which subgroup which strain of the virus you have, you better be treated already, because it would take several days to get that information. So you couldn't identify which strain you are at and then randomize accordingly. I think in this instance, at least, what you can do and what we've done is, again, we've done analyses supporting, yeah, exactly, retrospective analyses that looked at, okay, what did it, either the subgroups or included variant status as a covariate in our analyses and things like that, in order to make sure that there wasn't any funny business going on. But again, probably another area where there could be better, there are better approaches that one can think of.
right. It looks like we still have time, so I can ask one more question if possible. So you have one schematic to show the number of cases would have a surge in the beginning and then decline over the time. So I wonder if we are lucky enough to get the trial running at the very beginning, what the implication of this would give to our collecting of information.
That's a very good question. So you're referring to this kind of thing. So if I understood your question correctly, imagine you start your trial here with a treatment that actually does something, and so all of a sudden the curve flattens out like this. I can point you to a paper where we've looked at that. It's a funny business in the sense that there is a risk. If you have a treatment that works, because you have a treatment that works, you cannot collect enough information to answer your question anymore, which I think is just showing how important it is to not make premature conclusions and say, okay, this outbreak is over. I'm going to analyze and I'm going to publicize all my data and therefore decide, oh no, the treatment didn't do anything. But you need to make sure that you collect sufficient information before you make your decision, which sort of links to my sort of collaborative proposal that I've talked to. Rather stop, restart, and make an informed decision than potentially discarding something that's potentially useful.
Okay, cool. Thanks a lot. Do you have more questions? One more
question online.
Yes.
Test, are you able to unmute and say your question? I'm not sure if that's your name.
Yeah, sorry, it shouldn't say test. I won't bother explaining why it says that. Yeah, I'm sorry, I missed this, so I probably wasn't listening properly. How did you analyze the time to recovery outcome? Because that's censored. So I'm assuming you used some sort of maybe proportional hazards model, maybe Cox model. What did you do?
Yeah. So in the simulations, proportional hazards model was used. Yeah.
Cox model.
Yeah.
And then you censored everyone at 28 days.
Except if you died, you were censored at 29 days in the simulations, or if you were discharged before 28 days, obviously your status of 0, status of 1. What's that about?
Yeah.
Risks.
Okay, thanks very much. That's clear to me now.
Competing risks.
We didn't look at those in here, no.
Have one last question. You still have that. Okay, there's a competition. Maybe Martin, we will have Jack stay.
Peter is a guest, so. Okay, thank you. I'm very interested in the designs. I really found it useful to think about the endpoint, and especially the WHO or even the Lotus one. I think it's not really objective because it depends what the doctors did. It depends on whether they hospitalized the patient or not, whether they had a ventilator to put him on,
Enough oxygen.
Or oxygen and other resources. So it's not really a state of the patient of the disease itself. I don't know how.
That's a very good question. So on the Lotus trial, what we have done was, rather than thinking about hospitalization requiring supplemental oxygen, receiving supplemental oxygen it was requiring. So whether you had oxygen or not didn't make a difference. If you would have gotten it had you had it, you would be falling in that category. Same with the mechanical ventilation, for example. So we try to account for this in the Lotus trial, but obviously that is a problem. Obviously, if there are resource constraints in these kinds of endpoints. What I would suggest in this case is with collapsed categories that you can't distinguish reliably. So, rather than work with 7 categories, maybe 5 are the only ones that you can actually genuinely disentangle.
What about stratifying by site and looking at interactions?
Again, it's been done for sort of supporting evidence and sensitivity. But in practice, you will not have enough power to identify whether there was a meaningful interaction. In most cases, anyway. Interaction tests are notoriously difficult, require a lot of observation. So in the Lotus trial, there was no chance that we would have a
stratifying randomization. You can't do that. And group them either by country or by sites to different healthcare systems.
So we've explicitly not done that. Because we wanted things to be simple. Now for the Lotus trial, specifically not a problem because it was only one hospital that recruited, but in the recovery trial, for example, we didn't.
But it's a good idea to do it if you
have the resources, if you have the time, yes, of course, yeah.
Right. In the interest of time, I believe we should close this session. And the great news is that Professor Thomas Jaki would stay here for another half an hour for more questions or informal chat if you wish. So thanks for everybody's attendance. And I would like to invite you to join me in thanking Professor Thomas Jaki.